Welcome everybody to our CDC event today on advancing private and public sector collaboration to tackle the world's biggest problems. I'm delighted that Michael Anderson, CEO of MedAccess, and Maina Sahi from CDC are here with me today. I'm Liz Lloyd. I'm the Chief Impact Officer at CDC. Michael Anderson is the CEO of MedAccess. MedAccess is a social finance company which brings innovations to tackle issues of health in emerging markets. Prior to leading MedAccess, Michael worked across the public and private sectors in several high-profile roles, including as CEO of the Children's Investment Fund Foundation and as a Director General at the then Department for International Development, and a special envoy for the UK Prime Minister for the UK's Sustainable Development Goals. So I'm delighted that Michael is here today to share his unique insights on how effective cross-sector partnerships can bring about innovative solutions to tackle large-scale challenges. And with that, let me ask my first question to Michael. Michael, can you tell us something about MedAccess, a little bit more about its background, what it focuses on, and how it's operating? Thank you very much.
I have to say, I was not directly involved in the start of MedAccess. The company was created, the idea for the company came about from a number of individuals who were involved in public health, who were trying to work out what is the way in which we can most effectively get medicines into the hands of patients. They're readily accessible and readily affordable. And a number of people in public health have been working on this problem for some time. And the people from the World Health Organization, from the Gates Foundation, from the Clinton Health Access Initiative, who played a big role, from what was then DFID, now the Foreign Commonwealth Development Office in the UK government. A bunch of them came together and worked on this area of market shaping, which is helping companies to find ways to get products, health products, including medicines, out into markets faster, at lower prices, and of assured quality. And that was the challenge. So they recognized, this group of people recognized that there was a need to have some capital available to support that kind of market shaping. They put the idea together, but it was CDC, the company that you work for, and our parent company, that grabbed the baton and drove it forward. That, okay, we're going to create this thing. And so now we exist with, we're a social finance company with $200 million of paid-in capital from CDC. And we've been going since late December 2017. I was involved because I was at the time Chief Executive Officer of the Children's Investment Fund Foundation, which is a philanthropy based in London. And we've been involved in some of these market shaping transactions to help support companies to bring better products to market. And I was then inducted and asked if I would lead this, which I agreed to. And it's been very exciting since. I'm going to spend a minute, actually more than a minute, I'm going to spend a little bit of time explaining what we do, because what we do is unusual. We are an investment company, but essentially not for profit. We are looking to have a positive impact on health. That's our main purpose. How do we do that? Well, we look at the challenges that there are for people to get access to medicines. And those challenges are often, there are many, many circumstances in the world where there are good products, good medicines available, being sold in high-income countries, but they're often not for sale, or they're unaffordable, or the supply is insecure, or the supply is intermittent in low and middle-income countries. Why does that happen? One of the reasons it happens is that companies who produce these medicines and other health products are unwilling to be proactive in bringing them to these markets for very good business reasons. So one of those is that if you're a company sitting in Europe or the United States and you're getting good markets, good margins in markets where you understand the dynamics of the market, where it's fairly low risk. There's a hesitation to move into low and middle income countries because they're perceived to be risky, because there can be multiple regulatory hurdles. I mean, if you think about selling a medicine across sub-Saharan Africa, for example, in most cases, that medicine will have to be approved by separate regulatory agencies in each individual country. And if that regulatory space is poorly understood, or it's regarded as difficult to work in or bureaucratic, companies will many times not want to take on the burden of getting those regulatory approvals. Connected to that, there is a challenge of being uncertain about the demand, because funding levels are often volatile, uncertain, and the public procurement that you often have to deal with is unknown. So there are lots of reasons why companies perceive low and middle income country markets as being risky. And finally, we do look for tiered pricing. That is, we look for companies to have lower prices in lower and middle income countries. They're already covering their R&D costs up front from the sales they're getting in North America and Europe, so on. So they covered the R&D costs. We're just looking at covering the marginal costs. So we're looking for companies to have lower prices. And that often means lower margins, which companies are not inclined to go into unless they can be really certain they're going to get the volumes they need. So we are set up to provide guarantee finance to help take the risk out of moving products into those countries. That's our overall model. We like to say that we have a brain for business and hearts for humanity, and we use business methods and business staffing to try to tackle these problems in a way that will have really positive benefits for health.
So that is really helpful, kind of slightly theoretical framework and the kind of analysis of the problem that you're set up to solve. What does it mean in practical terms? What kind of initiatives have you worked on so far, and how have you collaborated to contribute to that success?
Right. Okay. So I'm going to spend a little bit of time explaining the examples because I think it helps to understand. So the example I'm going to explain in detail is one which involved contraceptive implants, which are rods of hormones which are implanted on the upper arm, and they can provide 3 to 5 years of contraceptive cover for women who would like to space out their children or not have children. Now, those implants are very popular across many countries today. They were not so 10 years ago. The products were sold by 2 big manufacturers, mainly in Europe, and the prices were really high. So one of the products was selling at $18 per unit, which is just too expensive for governments in Africa to purchase, or for NGOs to purchase, or for private patients in most circumstances. And so we, with the Gates Foundation, I was in then at the Children's Investment Fund Foundation with the Clinton Health Access Initiative, we negotiated with the manufacturers to bring the prices way down. And that meant moving from where they were before. One of them moved from $18 down to $8.50 on the price, per unit price. And that meant commercially moving from a high margin, low volume business model, and then moving to a high volume, lower margin business model, and taking advantage of economies of scale from significantly ramped up production. So that's the model. And once, of course, the product hit the market at that much lower price, and part of the deal was there was a guarantee which included a ceiling price being set. So, which meant the purchasers knew that for the next period of years, the price was never going to go higher than this level, which was agreed. That helps build confidence on the demand side. Governments know that they can invest in this product for the long term. And the companies undertook to provide volumes which governments could rely upon. So we reduced the risks for both the purchasers and the manufacturers on both sides. That's one example. So since MedAccess was created, we've done 3 guarantees. The first one was on a new viral load testing platform, which is used across sub-Saharan Africa. And we partnered with a company called Hologic, which manufactures in the UK, based in the United States. And they brought out this really effective, high quality viral load testing platform, which is absolutely critical for people managing HIV. Really, really important for HIV management. So they were able to come into the market at a publicly transparent price, which was on average about 30% lower than the existing prices, and everyone knew what the price was. They also knew there was a price ceiling, and the company announced publicly that they were willing to abide by the ceiling for a period of years, which increased trust. And what we provided to the company was we gave them the guarantee that they would achieve a certain level of sales for a period of time. And that gave them a de-risked proposition enough that they had the confidence to move into the market. We did a similar deal jointly with the Bill and Melinda Gates Foundation, supporting a brand new kind of mosquito bed net, a mosquito bed net that has 2 insecticides in it to kill mosquitoes rather than just 1, which is really important because in many countries, especially in West Africa, mosquitoes have developed resistance to the existing pesticide. So the mosquito bed nets were no longer working as well. So we partnered with the German company BASF to help them bring their product in for a longer period of time of assured volumes at a much lower price, 40% reduction in price. So that's the kind of deal that we've been doing in practice. We do have, and then during COVID, we can talk a bit more about COVID later, I think, but we provided a guarantee to UNICEF, $50 million guarantee to allow them to buy products in advance before the funding was in place, which would ensure that UNICEF could get access to the PPE, the oxygen equipment, the therapeutics, and so on, the diagnostic tests they needed to supply for COVID response. That's what we've done so far. And we are working on a number of other propositions on medicines, diagnostics, and vaccines.
Thank you. And it's very clear that there are a number of partners, a vast number of partners really, that are needed to bring these products into the market. What is it about the model, the kind of MedAccess model, that plays to the strengths of the various partners? How have you brought all these kind of stakeholders, and how do you manage that engagement?
It is like a symphony. Everyone's got to bring their own piece to it in order for the piece to work. Let me just take one of them. So the proposition, the guarantee we provided to BASF to allow them to bring their bed net to market needed a whole range of actors involved, and many of them before we were involved. So there's an organization based in Liverpool, the Innovative Vector Control Consortium, which just invests in new ways to, they have public money, they invest in new ways to control mosquitoes. So they had worked with BASF to help develop this technology. We spoke with them about many of the technical aspects and of course worked with the manufacturer, BASF. We also spoke with a number of other manufacturers because we don't want to favor any single manufacturer unfairly. So we spoke to others about, is there anyone else who could possibly bring a product of this kind to market? And in addition to BASF, we also spoke extensively with the World Health Organization. And that's one of the sectors we have to work with really closely, is the people who are specialists in public health, whose main concern is how do we maximize benefit for reducing morbidity and reducing mortality. And WHO provides the overall policy guidance and approvals, which are absolutely critical to ensure that there's that seal of approval from a regulatory authority that this product is worthwhile. And that helps build confidence among patients, among users in the case of bed nets, and among governments. So work with the regulatory agencies, work with manufacturers, work with the innovators like IVCC, the Innovative Vector Control Consortium I mentioned. We also work with the purchasers. So the purchasers in this case are mainly governments. And so we spoke with many ministries of finance to talk to them about what their priorities are, what they needed, what kind of product profile, exactly what sorts of volumes. And last, we speak with the funders, which in this case This was funded by the US government, the President's Malaria Initiative, funded by the Global Fund for the fight against HIV, TB, malaria, and UNITAID, which is a Geneva-based organization that invests in access to medicines. So all of those come together, and they have to all have essentially alignment on this proposition makes sense. And we spend a lot of time talking to them to understand the level of demand. Because for us, if we're going to take on a guarantee, if we're going to take on the risk of ensuring that the companies are going to get demand of a certain level, we have to really understand the demand well, understand the players are on board. But in the end, Liz, what we do is we contract directly with the company. So our legal relationship is just MedAccess and the company. We provide them with this financial guarantee to help de-risk the market for them. So although our contractual relationship was just with the company, in fact, we have these extensive relationships with a whole range of actors in the ecosystem. And that is critical, because if any one of those different actors objects strongly, they can kill the deal. And what for us, what that would mean is there's a huge risk we would pay out many tens of millions of dollars if the demand suddenly falls away for a reason we'd not anticipated. So we have a big financial incentive to talk to all of the partners, but also a big impact incentive. The whole point to make sure that the public health impact happens in the way that we want is to make sure all of these various entities are aligned and on board.
And you briefly mentioned COVID before. Do you see this alignment here for COVID? And through your engagement, through your talking to what is the demand, in emerging markets, what are the needs? What are people wanting at this particular point in time? So, is this model applicable in the response to the COVID-19 crisis?
Gosh, the needs of COVID are, everyone says they're unprecedented, but actually they truly are unprecedented. We have seen some amazing commitment and activity in response to COVID. I think the scientific community responded extraordinarily quickly to sequence the genetic material, and the life sciences companies worked very quickly on developing vaccines at astonishing speed, unprecedented in terms of the way that the development of the vaccines has worked, but also then the testing of the vaccines, seeing a compression of timelines that we'd never witnessed before in human history. We have seen business step up, we've seen scientists step up, we've seen the universities step up. Some incredible initiatives by university researchers bringing their very best of science straight into application quickly. We've seen governments step up. I think the level of deficit spending we've seen from ministries of finance would have been unthinkable, completely unthinkable several years ago. And governments have done things we thought were entirely gravity-defying because they're willing to respond to this. Specifically in response to COVID, the challenge for public health has been getting large volumes of PPE and oxygen equipment and diagnostics out into market quickly. And for low and middle income countries, they face the challenge of what is sometimes called vaccine nationalism. So there are challenges of equitable access to these products. There's huge challenges of we want this product if it works, but we don't want to pay for it now if it doesn't work. And that is a huge challenge. And governments have really stepped up to assume that risk. So for example, the COVAX initiative, which was created by Gavi, the Global Alliance for Vaccines and Immunization, that COVAX facility really is a vehicle for collective, pooled procurement of vaccines with a mechanism for equitable distribution so that rich countries and poor countries alike can get access to the vaccines. Recognizing that we're not going to have enough vaccines to go around for humanity in the first few months, so there's going to have to be some rationing. And if the rationing's inevitable, best that happens in a rational way according to sensible criteria of who needs them rather than just who can pay for them. There'll be a lot of that as well. We've seen the COVAX facility, we've seen the ACT-A initiatives for diagnostics and for therapeutics, which we've been working with closely to help support life sciences companies to bring better diagnostics to market and bring better therapeutics to market. It does feel to me that the one industry that has perhaps not stepped up as much as I would have liked is the investment industry. I think what we ended up doing was MedAccess provided a $50 million guarantee to UNICEF. And in order to do that, we put it together in a matter of just a few weeks rather than some months, which we would normally do with due diligence. And exceptionally, our board, supported by CDC, agreed to not charge a fee for that guarantee. It was provided pro bono on the recognition that there's just a huge need at the moment. And there's been a paucity of that kind of innovative finance available really quickly with entities willing to take on more risk. And it's a place where more innovation and more risk-taking is certainly possible. And I think that the investment industry as a whole could do more in this space.
Well, I hear you, and I'm glad that MedAccess can or has found a way to step up into that space. Can I just broaden the conversation out a little bit before we bring Maina in from the kind of the current to your own experience, which has spanned various sectors from private sector, government, philanthropy. What have you learned from these different sectors, including how they can all pay to these strengths in the health sphere and indeed in the current coronavirus crisis?
I think one of the things about the Sustainable Development Goals is that there's an explicit design, especially in SDG 17, to find ways for government, business, third sector to collaborate closely. I think there are some successes of that, but fewer than we would have hoped. And it can work very well where the collaboration is well structured. So I'll just say a few things about that. First, most of the big challenges we are facing as humanity are complex socio-technical challenges, which can be tackled through private sector or public sector responses or combinations. So there's that, I think, that underlying commonality. I do think that we struggle with a lot of prejudices, to be honest, where people who are in government are often suspicious of business because business, in their view, is always going to be motivated by profit, and therefore, constant suspicion is there an underlying motive here that we don't see? I see a similar kind of skepticism in businesses where there's a lot of skepticism about governments. One to be expectation the governments are bureaucratic or incompetent or inefficient. And I don't think that, well, in my experience, that's not true. So I do think that part of bringing these various entities together is a matter of finding common ways of collaborating. So a couple of good examples. I do think Gavi, the Vaccines Alliance, is a terrific example of the big manufacturers of vaccines coming together with the NGOs who work on access to medicines, along with governments and philanthropy, such as the Gates Foundation, and all working together to understand that business has a role to play in manufacturing these products, innovating, bringing new products to market, and that governments have to help fund this, and that there's a real reason to collaborate closely with governments taking on some of the risk and some of the big ticket prices, but business bringing what it brings best, which is the organization of the development of the vaccines and the systems for driving forward from innovation to commercialization to delivery. So that in my view, that is an example of business bringing its kind of efficiency and focus and capacity for rapid, effective action, along with the bigger picture thinking that the governments can bring, and everyone combining together. So I think that there is room. There is room for many more public-private collaborations of this kind, of people coming together in multi-sector collaborations. But there are some things we have to overcome, including understanding what are the motives and the perspectives of different organizations.
Well, thank you. That is a perfect point to bring Maina Sahi in, who works at CDC on strategy in healthcare and education across products and markets. And prior to CDC, she was a consultant and specialized in public system transformation in emerging markets. And Maina, you're very welcome as well. I think you oversee health strategy for health at CDC, and building on what Michael was just saying about the relative roles of business, of investors, of the public sector, of governments, and so on. How do you see the role of different actors, including, importantly, development finance in the health sector, and what role they can play in driving systemic change?
Yeah. Thanks, Liz. I hope everyone can hear me clearly, just making sure. Perfect. So, before I talk about the role of the different players in the sector or the DFIs, let me just step back and say what's really needed in healthcare. I think it is a given that it is very important to ensure that every person on this planet has access to quality healthcare. So access is there's the affordability element within access, but every person should have access to quality healthcare. And I think the world kind of committed to this when we signed up to the Sustainable Development Goals, and when we thought about the third Sustainable Development Goal, we pretty much emphasized this, and countries signed up towards this. In signing up to this and to defining this, it became very imperative that the way this can be delivered is through a fully functional healthcare ecosystem. In every country, you need to make sure that right from primary healthcare to tertiary healthcare, everything is in place for everyone, but also to think about the other enablers within the system, because we are in health today dealing with a changing disease burden. We are moving into a global climate crisis, or we're probably already in a global climate crisis that will lead to more health challenges in the future. And in the current environment, we are seeing what the world has come to with the pandemic. And so in this environment, it is very important to think of healthcare from the full ecosystem perspective. And when we do that, it is even more important to think of the roles of different players. When I step back and see what's happened in many countries, what I've seen is that in countries where the health systems have developed well enough, I wouldn't say they're still perfect, but well enough, you have seen the government actually laying out the framework for the sector. They lay out how and who will pay for healthcare, how and who will deliver healthcare, and what will be the role of the aid organizations, the government funding, the roles of the nonprofits and the private sector. They kind of lay out that framework. And actually in laying out that framework, they look at the whole diversity of demographic in their country. Where is the demographic located? What is the age and what is the need of the age? What is the income level and their affordability, the gender, et cetera, et cetera. So they look at all of that and kind of think of the framework in which healthcare can be delivered to this demographic, and also kind of set up, in simpler ways, a national health insurance scheme to deliver healthcare to those who can't really afford it, who can't really pay for services for it. And I think that framework is super, super important before we even think about what the role of different stakeholders can be in the sector. I think that early discussions on what that framework could be in emerging markets in low and middle income countries has started. In some countries, there is a national health insurance scheme set up and is trying to deepen its roots. In some countries, there is a framework for it and there is a lot of dialogue to bring it. But in today's environment, it is very clear that this really needs to be accelerated. And only once this is accelerated can we really define what the role of other stakeholders are in this. But once it's defined, I think it's important to make sure that all stakeholders themselves understand that they need to work within this framework. So as Michael alluded, the private sector's distrust sometimes in governments often makes them believe that they could do things outside of that framework, which will not really lead to results. Similarly with the nonprofit. And I think when I look at low and middle income countries, global aid has deeper pockets than government and sometimes tries to set the larger agenda, which could be beyond that framework, and therefore you see a lot of wasted resources. And so it's very important that all stakeholders, aid, nonprofit, government, and private sector work within that framework. As far as DFIs are concerned, I think the dialogue about working within this framework is actually really, really accelerated in the last 7 to 8 months. I think, having worked in healthcare for many years, I haven't seen the deepening of this dialogue as much as I've seen it in the last 7, 8 months. And it's sad to say it, but I'm kind of thankful for the pandemic for people to actually take notice of this. And as far as DFIs are concerned, I think the role is getting very clearer. The role is getting clear on 3 fronts. One, they are higher risk investors. And as being higher risk investors, we come into the market much earlier than many other investors do. And so it becomes our prerogative as investors to actually set the agenda of playing within that framework that I mentioned, but also keeping the impact lens high. And so in today's environment, we are seeing DFIs are already doing that, but then the private investors, the more private equity style or venture style investors are actually reaching out to DFIs to understand how we think about impact, because they are now starting to invest in these markets and are looking at it. So that's the first, which is setting that higher benchmark for development and impact becomes critical for a DFI. The second is to solve for the systemic thing. So our investment in MedAccess and our commitment to continuing to expand MedAccess's mandate is because we see systemic challenges in the environment that needs to be solved. And these don't need to be solved at just a country level, but it is a cross-country initiative. I mean, COVID has showed us the resource gaps, the supply chain gaps, and we've realized you can't solve it by just trying to solve it for Kenya or Nigeria or India, but you have to solve it at a more cross-country, more global scale, and that's why the systemic stuff becomes even larger. And I think DFIs have, both the money to do this large scale, but also the networks to make it happen, the relationships with governments, with aid, etc., to make it happen. I think that is the second thing. And I think third is around innovation. And this is what Michael was kind of, I think, in a way alluding to. I think in today's environment, I would have loved to see a lot more work by DFIs and other investors that showed that we are being agile and innovating to respond to this crisis. But I think that is a little bit lacking. And I think when I think about innovation, it's again, there are multiple angles to it. It's one is how do you finance? So it's not your traditional equity or debt investing, but it could be more blended finance products and etc. The second is creating more agile systems by which you kind of bring the money to the market or mobilize the capital into the market faster. And third is funding innovation in the sector itself. There's a lot of talk about health tech and health tech kind of solving part of the issue within COVID, but I really haven't seen health tech innovation being funded. DFIs have also stepped away in many times from funding medical innovation, more technical fields of innovation. We're starting to see some of that change, but it's still too small. But that's the place where I think there is a larger role for DFIs to play. So I'll stop there, Liz. I have answered this question in a very long way, but hope that was helpful.
No, great. Thank you very much. Michael, let me bring you back in again, just in terms of progress towards the SDGs and progress towards healthcare SDGs. Do you have any reflections on the progress towards the SDGs and how detrimental the virus has been to this?
Gosh, well, taking the SDGs as a whole, it strikes me that the virus has mainly had negative effects across the board, partly because it has affected economies so much, and despite the high altitude of some of the stock market at the moment, we are seeing declines in GNI across the world in many countries. So that's going to mean that finance ministries are going to take a hit, and that's just going to mean less funding for spending. I just think across the board. And there's also a second thing, of course, many of us will have observed, which is that the pandemic has sucked up the bandwidth people have to think about other things. I think so, although the world has valiantly tried to keep an effort on climate change during this year, it has been hard, and we've seen some attention come off of climate change. And, unfortunately, the Glasgow Conference of Parties, for example, had to be delayed. So there were a number of things where the pandemic has taken up attention. Specifically on health, I think there's no question that we're going to see increased morbidity and mortality profiles across a range of diseases. We've had projections from various epidemiologists on the malaria and HIV, TB front, for example, malnutrition. So all of those are projected to increase due to the pandemic. I do think, Liz, there is a silver lining. This year has reminded us how important multi-country collaboration is, and how we're all in this together on the same planet. And there is some utility in that. I think we've also seen it's accelerated the pace of innovation in many areas, as multiple people have observed. So not only the home working revolution and the discovering that we can get lots of work done by video rather than by flying around the world, but also we are seeing the growth of capacity and understanding of public health in many countries that haven't had it for years. I mean, it's often observed that the East Asian countries responded better to the pandemic because they had recent experience of other epidemics and had better public health practice. So I think the whole world is going to see some of that. But the SDGs as a whole have certainly taken a hit this year. And it's our job to collectively learn what we can from this and take what is good from it and continue to accelerate.
So I'm going to turn to some of the questions that have come in. There's some very interesting ones that have come in before we maybe return back to the panel. Michael, this is a specific one on the long-term implications of the MedAccess model in terms of the effects on local manufacturing and incentives to manufacture locally. Do you think there's a risk of crowding out the local market by providing these large-scale volume guarantees?
So the answer is yes, there is a risk of that. And I am optimistic we're going to find ways to counter that in most circumstances. So we're seeing, particularly in sub-Saharan Africa, we're seeing a growth in government emphasis on local procurement. So for example, the South African government requires that some of the products manufactured for their tenders are manufactured locally. Now where we can help is we can help secure global supplies of the API, the active pharmaceutical ingredient that local manufacturers can use. And by pooling procurement across countries, we can help local manufacturers take advantage of economies of scale that would be impossible if they were just working within their own local smaller market. So I think there are real opportunities to focus on the domestic manufacturing. And it feels like a very exciting time for growing domestic manufacturing, because many governments are putting an emphasis on that now. And because the supply chain challenges during 2020 pointed out to the rest of the world how local as well as global production are important. It feels to me like a place where we're going to see more capital going, and certainly we will be looking to support local manufacturing wherever we can. I do think, Liz, it's important that we counter honestly, directly, some mythologies. I mean, there's a prevalent mythology that local manufacturing will always be lower cost, and it's just clearly the case that that's not true in many cases. There'll be times when we've got to pay the extra premium to get the local manufacturing. And I think that governments and companies are going to have to rise up to that challenge.
Maina, would you like to add something about what we're seeing in terms of local manufacturing as well?
Yeah, thanks, Liz. You know, given COVID, there was, like Michael said, there was a belief that local manufacturing will pick up and it'll be cheaper, and actually it'll encourage the local manufacturing environment. And I think we don't realize that local manufacturing requires an entire structure to actually operate, right from the technology to the manufacturing capability, but also the resources required, the workforce, as well as the inputs that go into that. And then what happens after manufacturing, you need to make sure it's distributed and it's actually used in the right way, so you could manufacture a particular equipment or a medicine, but if it's not delivered in the right way, it's not stored in the right way, the logistics chain doesn't exist, then that really doesn't have an impact. And so what we have seen, at least, is that in countries where this kind of the value chain of manufacturing already existed, that value chain has actually started to see escalation of players across that value chain. But in countries where the value chain did not exist pre-COVID, there hasn't been much movement, so it's not like local manufacturing has kind of encouraged over there. And so, in the short term, you really need to find a way to bring resources from other markets at the right cost to these markets. And these are the markets which are the low-income countries. These are not India's, but these are, India still has the value chain. These are the smaller markets, in Africa, for example. The second important thing to understand is that there's also a demand side play to this. Local manufacturing will come up and be useful if there is a demand, if there are people, the demographic is demanding the medicine or the vaccine, or there are hospitals or clinics that are demanding it, and there's a demand side. So I think, and therefore the MedAccess model is excellent, because in a way MedAccess works with the demand side forces, the gates, etc., and brings the product, for lack of a better word, I'm using the word product, but brings the product at that cost that meets the demand, and actually the demand then actually can go up. And it solves the demand side. So when the value chain for manufacturing actually gets set up in the market, it's kind of plug and play, because the demand already exists, the distribution already exists, the usership and how to use it already exists. So I think those are important considerations. But in my view, again, COVID has kind of accelerated manufacturing across value chains and markets where the value chain already existed. But in the low middle-income countries, which didn't have this, really nothing has happened.
Michael, let me turn back to MedAccess as a company, in its sort of early years. We've had a question: can MedAccess become self-sustaining in the long term? Does the business model need to be non-profit, or can it have a portfolio cross-subsidy approach with profit and non-profit initiatives? So a question about the business model, and I guess the replicability of it as well.
Well, that's a great question. One that, to be honest, spend a lot of time thinking about. As a social finance company, we aim to be sustainable. We aim to be financially sustainable. We have to cover all of our costs and cover all of our risks and generate enough income to cover that. I think the more, and we can do that. At the moment, we found ways of charging fees to the companies we work with to generate income, and that plus these hidden subsidy we get from the capital that we have helps us to achieve that financial sustainability. I think the more interesting question for me is which impactful transactions would have to be ignored or left aside at the cost of us remaining financially sustainable. And it seems to me that there will be some room for cross-subsidization. So one thing that we've thought about is, can we work more in the upper middle income countries where markets often don't work very well, and we can help bring some predictability and some trust into those markets, partly by bringing partners together, partly by helping manufacturers come in at lower prices. So there may be markets where there are slightly higher margins for us. But the other thing that we're thinking about at the moment is, should we be explicitly looking to have some of our fees covered by grant money sometimes, where there's some blending of some grant money plus our capital deployment. We haven't gone there yet, but that's one of the things we're thinking about. I do think that one of the challenges for business is that there's lots and lots of funding out there, which is in the form of grant, that is seeking no return. And there's a lot of funding out there which is seeking complete return of capital plus a small margin, which is sub-commercial, but seeking some margin. What seems to be missing substantially is the proposition that, yes, I'll put $1 million out there and I'll expect to get 80% of it back. People are always looking to get 100% plus something back. And so that business model where you need some recognized subsidy coming in from public funders, plus some private capital and blending them well. There's been a lot of discussion about blended finance, but I think there are very few models where it actually works clearly and well. Maina mentioned earlier, the importance of public provision of purchasing goods and services for health. And I think at the moment that happens mainly by contract, governments contracting with private entities to deliver those services. And I think we need to see more in the way of how do we blend some of the subsidy at the investment end. So that is certainly something we would look to explore. The person who's asked the question is certainly reading my mind in terms of what's next on our agenda.
I think perhaps the next question is a question which comes after you have found the way of creating more kind of buffers, because it's a question about whether you've considered MedAccess support to health innovation, for example, taking technology risk and not only the kind of volume or guarantee risk that you talked about before. So once you've created a bit more kind of capital buffer, I think there's a question about whether you're thinking about this as well, or even if that kind of subsidy would be needed.
Well, certainly in terms of the innovation, the risks tend to go up as you move up the value chain towards more R&D. So that would traditionally be more in the space of venture capital. I suppose that the proposition might be for a social finance entity that we would do that in a place where there's not a commercial return, or it's unclear there's a commercial return. And I think others have done that. So for example, the Global Health Investment Fund is a fund which specializes in investing in those propositions where products still need to be tested before they get commercialized, but that the return on them might be sub-commercial. And so that kind of proposition, I think, is a really important one. And we do see a blending of public and private money. So, the National Institute of Health in the US, BARDA, or the research councils in the UK do invest public money to help that innovation alongside private money. I think that for MedAccess, our guarantee model might well work partly up the value chain at times, but I don't see it as our main entity or our main challenge, because there are so many proven products which are clinically effective and not accessible in the world. That's just low-hanging fruit. Let's go for those. Let's get them out. We don't have to wait for the new ones to be developed.
We had a question also about geography, about how you think about selecting the countries or regions which benefit from the guarantees. and whether you have views about, you know, a narrower geographic focus to kind of prove success or demonstrate success and then ramping up, or kind of a broad approach. You talked about it a little bit in terms of the kind of financial model or the business model. I guess this is a question which covers both the kind of impact or the kind of public health outcomes as well as the business dimension.
The universe of beneficiaries for our guarantees by our mandate have to be low and middle income countries, populations in aid eligible countries. By the World Bank definitions. So we would not work in countries outside of that set. Within that, our guarantees work best when we take on multiple countries at once, because it's a way of diversifying risk across multiple geographies. And you can get the economies of scale which allow for really efficient manufacturing. So we instinctively go for multiple countries. That said, most products have a regional footprint and a regional need, and we look carefully at where is this product needed, and where is it most likely to be effective. Finally, the partners we work with, the purchasers, the Global Fund, WHO, the companies, often have reasons why there's specific geographies that they want to focus on, either public health reasons or, for some of the companies, just because they don't have capacity to work in all countries simultaneously. So the answer, to be simple about it, the answer to the question is we take many factors into account in making those decisions, but always driven by the concern for equal access wherever we can achieve it.
And then there's a question which I'm going to summarize in the interest of time, which is really about a comment that, you know, MedAccess is currently kind of bridging gaps in either government or market, or the market's current structure in providing access to healthcare for others, and to what extent MedAccess advocates, as in terms of policy, I think, different kind of models and structures for market structures, and I guess government structures, but that isn't in the question, in terms of provision of healthcare to others. But it's more one about kind of, you know, the place MedAccess operates in terms of market.
That's a really interesting question. I mean, one of the ways we think of ourselves is we exist to help make markets work better, with better competition, with better pooled procurements, with better security of supply. It's better to have multiple suppliers in the market providing similar products rather than just one for security of supply. We like to see transparency of pricing, a range of, so we are concerned in how the market is structured, and we care a lot. We work closely with partners who are trying to structure markets. So some markets are really well functioning and well ordered. I will take the market for HIV treatments, because of the role of the Global Fund and PEPFAR and various, and so much world attention to it. There's a really good understanding what the products are, a range of manufacturers supplying them and so on. But if you turn to, say, the market for insulin or other kinds of diabetes treatments, there's nobody in the world trying to bring order to that market. So, we've seen data about really inconsistent pricing of diabetes products across a range of countries of similar income. And what we're not seeing is any pooled procurement there. We're not seeing common regulatory standards. We're not seeing systems for trying to find multi-country solutions. That's one of the places where we would like to be more active in the future. And it's not so much that we'd be doing advocacy. It is just simply trying to stitch together a more sensible approach to aggregating demand. And if you can aggregate demand with common standards, then you can start to think about how do we support supply, whether it's local supply or global supply, which can come in at a lower price and build trust amongst the various players. So there are some markets that are really disorganized at the moment. And that results, unfortunately, in very unequal access to products at really unequal prices. It would be our ambition 10 years from now to say that we've helped change that.
Well, I think with that sort of going out broader question, we can come to our very final kind of thoughts. Maina, in light of the conversation today, what would your challenge or call to action to leaders across the public and private sectors be to advance more impactful collaborations in this area?
Yeah, thanks, Liz. So look, I think before even we talk about the leaders, I think right now the pandemic has kind of showed us that in markets where the healthcare system is probably not developed, the public has realized, the demographic has realized that this is at risk and has actually, preempted and taken more precaution. And the virus is much more contained in some of those countries where the healthcare ecosystem is not, as developed. And in countries where there is a good healthcare ecosystem, the reliance on the government and the healthcare system has been so high, then the people haven't really taken responsibility, and the virus is spreading. I mean, we're seeing second waves right now and third waves. So, we're seeing that. And so I think, like, before even I talk about the ownership of leaders, I think there is, going into the future of this world, there is an ownership on every individual to understand that they have a responsible role to play in the healthcare systems in their countries, and not to burden that healthcare system, but also to take precautions not to spread any viruses that come in the future. And then they have the second responsibility of driving accountability. And I think that is super important. Before we tell leaders what is the call of action, I think the people of the country have to drive accountability. That's super important. And I think there's a huge role for advocacy organizations and nonprofits to play in this. As far as, the things that I would like to see, is twofold. One, from governments, I really would like to see how they want to achieve SDG 3. I've seen enough dialogue. I've seen some policy changes, but nothing that gives me confidence that they have really thought through the full framework of how healthcare ecosystems will develop in their countries in the next 20 to 50 years. And so I really would like to see governments think longer term and actually set that framework in place. As far as private sector is concerned, I really would like to see a lot more innovation on the ground. I think Michael alluded to them trusting government and working within that framework what they set up. But I really like to see a lot more innovation, especially in our countries that we work in the low middle income countries that we work in, and not just reliance on the Western world's innovation.
Great. And the very, very last word to Michael. Call to action in 30 seconds.
Yeah, we're out of time. So I'm just going to say one, which is for businesses working in healthcare, take responsibility for measuring your impact on healthcare outcomes, not just profit and loss. It is that one thing, is if you could help to keep track of what is the impact on public health of what you're doing and help inform decision-making with that, I think that would be the single most important thing.
Well, Michael Anderson, thank you very much, CEO of MedAccess. Thank you for your time today. And Maina Sahi from CDC. It's been a really great discussion. And thank you all for attending. And with that, we will close today's session.
Thanks very much.
Goodbye, everybody.
Thank you, Liz.